There we go. Hi, welcome. This is Diane Bahr, everyone. I'm so excited for her to be here. She has a beautiful bio. She's a speech pathologist, and I want to read it because I want to make sure that I don't miss a thing, because Diane has been pivotal to the speech pathology field and feeding therapy and all the things that she's done. So I want to introduce Diane. Welcome, Diane.
Thank you for having me.
I'm so excited that you're here.
I'm honored.
Oh, I can't even believe you said yes. I was thrilled when I got your response. So parents are going to learn so much from her. If you're a therapist listening, just buckle up. There's a lot to learn. She has over 40 years experience. So everyone turn your ears on. She's treated children and adults with feeding, motor speech, and mouth function problems. She's also an infant massage instructor. She's obviously honed her skills as a feeding therapist. I say obviously because I've studied her work for years. She has published so many books, and the ones that we use in our office, including Oral Motor Assessment and Treatment, Ages and Stages. There's 2 parent professional books that actually I love, I use as a professional. That's Feed Your Baby and Toddler Right, Early Eating and Drinking Skills. And then also, Early Eating, Drinking Skills, Encourage the Best Development, and my favorite, Nobody Ever Told Me or My Mother That. One of my favorite books. Yes, I have that one right here too. And then another one, Everything from Bottles and Breathing to Healthy Speech Development. So everything on here that she's going to talk about today is going to be some amazing information. So Diane, welcome.
Thank you.
Absolutely. So we wanted to start a little bit with your professional background. If you can just give us a little information as to how you got started and how long, how things have evolved through your career.
There's quite a bit of it. I'm very fortunate in that I've been able to focus on the same kinds of things across age groups and populations. And so while I started out in a small school system in Maryland, which I actually loved, I had your typical speech kids, and we were just starting to get into language. And so I really enjoyed it. There were only 12 therapists in the county. We met monthly, and it was great. But I had this one kid who had dysarthria, and I really didn't know quite what to do with him. So
Can you explain for our parents what dysarthria is?
Dysarthria is slurred sounding speech related to muscle dysfunction. Okay. And so we see it in the adult population with people with strokes, and we see it in children as well. So I went to the Maryland School for the Blind for 10 years, where I was a therapist, but also part of a major feeding team. So from September until November, all we did was feeding. It was OT, PT, speech, education, residential, anybody else we needed. A gastroenterologist.
What was the age group on that, Diane?
That was birth to 21.
Birth to 21.
Yep.
Because I think people are interested in the fact that a speech pathologist can work with a newborn and what that looks
like. I'm working with one right now who's just 1 month adjusted age and is still in NICU, and I'm helping to guide that family with their treatment. So, because those are the ones that often fall through the cracks.
Is the NICU babies?
Yeah, the NICU babies, because the early interventionists are wonderful, because I'm a very, I don't want to just say positive, but I am positive. I like to look at the good side of things. And so part of what I'm doing and moving forward, and it's similar, let me turn my heat off. It's similar to what you're doing, is I want to move beyond the basics to help to mentoring and consultations where we can get children better served. And especially helping families, which, we'll talk about, which is what you do and what interested me. So School for the Blind, then I went to Maryland General Bryn Mawr Rehab, which I was a senior on their brain injury unit. And see, at the School for the Blind, our kids had a feeding program that was done throughout the day, because we fed, and then we trained the people working with them, including the house parents in the evening. We had some children who spent the evenings with us. And so they all went home on the weekend. And then we had family education where we brought the families in and trained them. So, I'm spoiled. because I had all the stuff we need now, which is hard to get from pretty much from the start, from the early 80s. And during that time, Suzanne Morris, who is still my mentor to this day, became my mentor. So I would go study with her for weeks at a time. She is the co-author of Pre-Feeding Skills with Marsha Dunn Klein, which is one of the best feeding books out there for therapists. So anyway, after that, I went to Maryland General, Bryn Mawr Rehab, and I worked with age 16 to 99. I also filled in on the stroke unit and occasionally in intensive care. And so I could use a lot of the information, but at a different level, because when you're with adults, you're going to do things differently than you're going to do with children. So, you know, of course, we want to do adult-like things and you're going to handle it differently. So I had a chance to figure that out. Then we realized, a colleague and I, Lori Sova, realized we have 3 like speech programs within an hour. I'm from Maryland, and 1 OT program, and even more speech programs in the DC area. So we realized there's no feeding and swallowing course. So Lori and I developed one, and we taught it like 11 years.
And this would have been what time that there was no feeding course? Like what year?
This would have been 1992.
That late?
Yeah. So
wow. And I want to do a shameless plug that this is the book Diane was talking about that every therapist needs, by the way. This pre-feeding. This is Diane's mentor. And
I have the originals that Suzanne wrote from Chapel Hill, North Carolina, you know.
Yeah, that one is a different edition, a second edition.
Well, there's the 1980 something edition. The one you have is 2000.
Yeah, that one's a second.
Yeah, and so, which is still very appropriate, and I highly recommend it. Like,
I want to notice the thickness, Diane.
It's right down there.
Look at the thickness, and this is pre-feeding skill. This is everything. This is everyone. I mean, this is amazing. The amount of information here and the amount of information that, you know, parents can't be expected to know, but the amount of information we can share with this population, even before they're eating well, how to get there.
It's literature based, and Suzanne Morris is the only one who's really done a longitudinal study on typical feeding, which is when I went to my next, so I started teaching part-time at Loyola, weirdly in the speech department for feeding, and in the reading department, which is another area of interest of mine. And then I went there full-time for 6 years, where I worked in their clinics. We had 3 freestanding clinics. I worked side by side with the graduate students. We had people of all ages. We had 1 clinic where we focused on children with Down syndrome. And what we saw there was that we could keep children with Down syndrome on track if the parents were able to follow through.
100%. Yeah.
And it's really not rocket science. So it's much simpler than people think it is. And so that's kind of what I'm back to now. After that, 2000, I went into private practice. And and one of your questions is about working with an OT. I can't remember when I didn't work with an OT.
Good for you.
So, you know, in private practice here, I have Tanya Stegan Hansen, who wrote the book Just Take a Bite. I'm very lucky. She's also trained by Suzanne Morris. She's trained in sensory processing, neurodevelopmental treatment. Even though what a lot of people don't know about me, I'm a fully trained body worker, but I took those credentials off because I don't want people coming to me for that.
Right.
I want to work on a team.
Yes.
As you talked about with Dr. O'Rourke, and as you guys do.
Yes.
So I want that full team, but I don't want it segmented. I know that was another comment that she made as I listened to her yesterday at her wonderful presentation.
Yes.
So, you know, private practice, then COVID came.
Can you speak to, Diane, a little bit about, can you speak to what you think is so pivotal about OT? I mean, I have my reasons, and that I'm trained in a lot of things that, like, I attend the same courses that Terry, my business partner, who's an OT, but I don't have people come to me for that. But I think it's so important that I see that in my kids, that I can be
And
a
you
good
follow,
diagnostician.
well, you follow through.
Mhm.
So we did a lot of co-treatment at the Maryland School for the Blind, worked in each other's spaces. We were what would have been called a multidisciplinary team or interdisciplinary team. They're slightly different, but we actually, OT, PT, and speech, we went together. We did the evaluations. We were all on and off trying different seating because our kids mostly had cerebral palsy at the time. Okay. With other, genetic disorders that went along with that. And so, so we always had the OT, and we would do groups. And then when I was in a speech session or in the classroom or working with the families, I could help follow through on what I had learned in OT in terms of positioning. And it's not just sitting in the right chair.
Right.
So I do a lot of work, especially with babies on their bellies. Also, people have skipped over side lying, and we'll talk about that because there's special development in side lying, and it's one reason our kids aren't rolling these days. And our kids are spending an inordinate amount of time on their back. So when I go in with Tanya, she does, and our oldest patient has been 25, a young man with brain injury. She's probably had older in her clinic, but we're both getting older, although she's much younger than me. But we're still crawling around the floor, working on swings. We're not working in chairs most of the time,
right?
Unless it's appropriate for whatever we're doing, like eating and drinking.
Right. And we do that at our place as well. We have a therapy gym, and we work on integrating those primary reflexes and those early motor patterns. And sometimes when I talk to other speech pathologists, certainly not you, but younger speech pathologists, or when I lecture and talk about the importance of SLPs knowing motor milestones and knowing the importance of movement and how movement is the basis for everything, and that we need to work with our motor therapists who know that inside and out. You get a lot of blank stares because they don't understand how that works. But obviously working, as you know, on an island and doing just your piece of the pie, it's just not enough. You're just not.
And I got really lonely. So
once
I went into private practice, but the thing about Maryland General was we were what's called a transdisciplinary team. So if the PT wanted the person walking, we were walking and talking, and I treated and they had beautiful facilities. So I treated right in their gyms. Because they had enough space. So if they wanted something done, I could go in and, and then because we were a transdisciplinary team and we wrote all our goals and objectives together, they could see what I was doing. I could see what they were doing. They could come. I'm Feldenkrais trained. The one PT I worked with was Feldenkrais trained, so she could facilitate the body movements. And back to what you said, and also private practice, I had a wonderful PT I worked with who was right up Interstate 95. And her name is Pat Winders. She wrote the book on gross motor skills for children with Down syndrome. She's awesome. And a lot of times they would come from her office where she'd done the body work and then drive right down to my office. And then I had a wonderful OT, Vicki Smith, who all of us worked even though we weren't in the same office. And I had a big office in Maryland. So if you ever see my courses, which are all online now, you'll see this apartment where I had a swing and, I had a trampoline and, we could do whatever we wanted to do there. So back to the reflexes. I have started putting together information we are losing important information we're losing. So down here, not only do I have pre-feeding skills, I have Lois Bly's book. She was my NDT instructor, even though I'm not NDT certified, but I was an NCTMB. I did full bodywork training because I just felt as a speech therapist, I didn't know enough about what the rest of the body was doing. Great. So I don't act as that, but I work with people who do that, and I understand why they are. So Lois Bly's book went out of print, and she has the best birth to 1 year information with pictures of what babies should be doing in all different positions. So I have now taken her information since it's out of print, and I can't find it anywhere else, although I can send you her. I do have a PDF of all of her literature base. And the same with pre-feeding skills, it's literature based. All of my work is literature based and criterion referenced as much as possible, which is one reason I wrote this one on feeding, because we had gotten some new literature on feeding. So this one focuses on feeding, and I wanted to get the new literature out there. This is 2010, this is 2018, this is 2000, 2001. I wrote this because I had no textbook when I was teaching at Loyola. So
you had to write your own textbook on top of teaching the class.
I begged everyone to write it, and we were using pre-feeding skills in some other books. But this way we could put everything from birth, infancy, birth to geriatrics in one place. And then it's very criterion reference, so you see exactly where the literature came from. And this one, not as much, because this is a publisher for parents, and so not as much. Although this one, while I stayed still very parent friendly with it, I want parents to know the literature, because here's what happens. And I'm going to share with you the new checklists I'm making, so you can put them on your site. They'll be on my new site. It'll have a combination of Lois Bly's work, Shirley German-Volpe's work, which are both.
You froze on me.
There I go.
Okay, there you go.
I froze.
Froze for a second. I saw it.
Shirley German-Volpe's work is still there, still available. She based her work on assessments that were based on the literature, and she looked at all different aspects of development. And Lois Bly, being an NDT instructor, she based hers on literature as well. But now we have these books out there that I'm not criticizing, because I'm glad they're there, but they don't have the kind of detail parents need, especially when the pediatrician says, what's the literature on this?
Right.
So I want parents to have that information.
Right. I want them to be empowered when they go to see their pediatrician and they have an issue that they see as an issue.
Right.
And if the pediatrician is like, well, the growth chart looks good and they look healthy, I want that parent to know what to ask, what to say, to request that referral, and be able to back up those concerns.
Okay, so here is something to add to what you're saying. And you already mentioned reflexes. So when we had lots of kids with cerebral palsy, and it was evident they had cerebral palsy, the pediatricians at that time checked full body reflexes, oral and hand-mouth reflexes. Then we got better birthing practices, and it wasn't quite as necessary, but Tanya Stegan-Hansen and I presented for the American Academy of Cerebral Palsy and Developmental Medicine, or it's got those words in some order, and a few years ago. And what we heard there was there's more cerebral palsy today than ever. So as I'm looking at kids, which Dr. O'Rourke mentioned on the spectrum, which was during the 90s, that population rose before our eyes. we are seeing that many of them, when they get to be a little bit older, are being identified as having mild cerebral palsy. And so that's where your your OT, your PT, your integration of full body reflexes are so, so important. And so what I'm doing in the checklist that will be free on my website, and I'll give them to you for your families, is to say, this is what a 1-month-old should be doing. This is what a newborn should be doing. This is what a 1-month-old. I don't want to overwhelm anyone. And if a child has a problem, then just as Dr. O'Rourke said, and you said, we have to get to the appropriate team member.
Right, exactly. Because a lot of the things that we work on, and when Dr. O'Rourke and I, we've been working together for a while, so many things are prevented by that first initial step. And I want parents to not be nervous about taking that step. I want them to see this as, wow, here's an opportunity to not have this domino effect. Instead of having kind of a stigma feeling about attending therapy, I want them to see that there's some great benefit. And it also doesn't mean you have to have a scary diagnosis or anything to attend therapy or to request therapy. I want them to see these nuances, like in your checklist, and go, you know what, my kiddo's not doing those things quite yet. I can go see these professionals, they can get me on track, and then it won't, turn into something later that has to take a longer amount of time or be scary.
Right. Yeah. And that's why you and Terry work together. And so while each of us now in Las Vegas are in our own practices, we now have a really good OT. We just had a great PT move to town who's on the same wavelength as us. We have 2 SLPs who are on the same wavelength with us. We have a dental oral facial myologist. We have 2 pediatric dentists, 2 pediatric orthodontists. And we have a vision specialist. And so while we're a relatively new team, because Las Vegas is finally coming together as a medical community, I mean, I was spoiled in Maryland, the Baltimore, Washington area. It is like a medical mecca. Wow. So, I was very spoiled. And when I came here, it took a while. I've been here almost like since 2004, but it took us a while to pull these people. And now we have people moving here with the skills. Yay.
Yay. Right. Absolutely. We're looking in our area too. We need our missing member is really an ENT. That's our missing member.
Too. And we think, when I talked to the dental oral facial myologist yesterday, she thinks that one of our dentists that we know knows an ENT here. So we'll check that person out. But Suresh Zaghi is my ENT. He's in LA. And he helps us out whenever we need it. He'll come online and work with our team.
Oh, that's amazing.
We're very, very lucky.
Well, maybe you can hook me up, Diane.
Yeah, well, we're not that far from LA.
Yeah.
So
you're close.
Yeah. So I want to go to the mission and the vision of, what I'm doing now.
Yeah, let's do it.
Okay. So everybody in the audience, I gave Stacy and Terry a PDF, which they can share with you. It has much more information in it. If you're a professional, you'll probably love it.
It's fantastic. It's like 38 pages long. It's not simple, but it's wonderful.
If you're a parent, don't freak out.
Don't panic.
Because I'm going to break this down for you in a very easy way.
Okay, I'm ready.
So I recently taught a really large course with the Breathe Institute, and now all that's on video for me, so I don't have to teach. What I'm moving out of teaching and direct treatment, which I was doing right up to COVID. And I'm moving into more consultation, mentoring, helping families find what they need, because this really is family treatment.
Yes.
So I don't know, do you want me to share this one screen?
I want you to share whatever you'd like, because I find it all fascinating. Can you tell me what you mean by family treatment? Is that what you're going to go into?
That's what I'm going to go into. Okay. And then we'll come back and we'll, so you have to able me.
I have to able you. Not me. Hold on.
And if you don't want to, I'll just talk you through it because you guys have a handout on this.
No, I mean, I can. It's just, am I jazzy enough to do it? Normally when I go to the top, it gives me those.
Oh,
things.
don't worry about it.
Okay.
We'll just talk it through, have a chat. Everybody will have their handout, so it'll show you. So on my new website, which is where I'm focused right now, it's the old website that we're updating. I'm talking a lot about what we learned through my years of teaching, which started in 1989, and my years of treating, which started in 1980.
Yeah.
And so really all children and adults need the best possible, and I'm reading this off on my website, possible body, very important first. And, Dr. O'Rourke mentioned the posture and the changes she's seen over the last 30 years. I've seen similar changes over the last 40 years, and we can talk about what that is.
Yeah.
That we need good airway development, which you talked about. We need nose breathing, appropriate tongue resting posture, good mouth structure and function. And it all starts with the baby's tongue resting in the palate, which is how they're born. And when you look at a baby in either of these parent books, and I also have a free parent professional course that you're welcome to, you'll see that most babies, unless they're preemies or something else, even children with Down syndrome, they start out with a nice broad eye area, a good nose angle, a straight lip line, a closed mouth and nose breathing. And yet this is the other thing Dr. Bork talked about. This can go off kilter very quickly and very easily.
Yes.
So here's what you'll see on my website. We're taking our time with it. So this won't be up right away, but you have it.
Okay.
So I want to create awareness via accurate, consumer-friendly, literature-based information. So I want it to be consumer-friendly in plain words. And if it's not in plain words, then you guys, at the end of the presentation, you will have my contact information. I answer questions every day.
Yes, she's very good at answering questions.
Yes, I feel that's kind of where I've always done it, but now I feel that's my mission. Yeah. I want to provide families, and this doesn't matter if you've got a newborn or a 99-year-old in your house. And professionals with online and community education. So eventually, right now, my course through Northern has some video demonstrations, and my other courses, you'll see me doing treatment. But I want to create like a YouTube channel or whatever that will kind of go along with all this. And it's all going to take time, just like Stacy and Terry are doing.
Sure.
And then we want to prevent, or if we can't prevent, we want to correct body, airway, and mouth structure function problems.
Yes.
And so just because somebody's gone off track doesn't mean we can't get them back on track.
Correct.
So I was a bottle-fed baby. I was a very sick baby. I had a high narrow palate. And if you look here, I'm going through palatal expansion now to open my airway because, again, Dr. O'Rourke talked about the roof of the mouth being the base of the nose. So when you expand that palate, you get a more open airway. And then, I never give up. So I don't say because you're a certain age. I know insurance companies, and I'm not putting them down. I know they go by statistics, but I have a different view and a different take on what I want to do.
Sure.
So, and it's a result of what I grew up with, as a therapist. So, and I want this to result in generations of children and adults with the best possible skills.
Yes.
Okay. So I want to create that cultural shift. Now, there are certain things that are impeding this right now. And I'll get back to what Dr. O'Rourke talked about in terms of breastfeeding.
Sure.
But here are two things, and you wouldn't think, oh, she's 40 some years into this, but because we did such intense work with the Breathe Institute and we saw so many patients of all ages with and without specific disabilities. So, but they all had something going on here in the airway in the mouth and off in the body.
Sure.
So for example, I saw a 51-year-old who was a case of one of our participants. And his shoulders and his arms worked together and his hips and his legs worked together, but he had no movement in his trunk.
Sure.
And so one of the things we know is that movement that you develop as a baby is a precursor for us seeing similar movements in the mouth, the wrist, the hands, and the eyes, because those are all fine motor function. And so, in fine motor meaning you're more refined motor than gross motor here.
Got it.
And like with a 51-year-old, he could do yoga, he could do Pilates, he could do a specific walking program where he gets some of this going. It's not hard to get the body doing what it's supposed to do. Mm-hmm. He also had his pelvis tilted, as many of us do. So we got him on an ergonomic chair like I'm on, which has a little slant here and gets me on what's called the sits bones, right, which then connects to the spine, which then connects to the neck, which then connects to the mouth. So it's like a train, really. Right. It's not all that difficult. So in babies and toddlers, here's what we saw. We needed good body movement, which is why I'm developing the checklists. We needed good movement development as a result of good body development. Mm-hmm. And that's not just tummy time or on the back, it's also in sideline. There's specific development. We need good feeding, which we have a lot of information on. And we need good mouth play. So for example, you'll see my grandson back there with this Beckman Tri-Chew at 6 months, because we, and Dr. O'Rourke addressed the pacifier. Chewing is just as organizing as sucking.
Yes.
So if, you know, I'm not saying never use a pacifier. I have guidelines in my books for pacifier use. But I'm also saying we're spending too much time on pacifiers. So she said 3 months. Harvey Karp says 5 months. The research out of Europe, where they looked at 500 children, said 5 or 6 months, you're going to start to wean them from the pacifier. So just like she said, anything a bottle nipple, a pacifier nipple gets in the way of the tongue going to the roof of the mouth, which we use for swallow.
And right around 5, 6 months, Diane, even in your books, it talks about that transition to chewing being so important, like you're saying. So that is a nice segue if someone is, you know, a little one is pacifier dependent, is getting into the chewing pattern, which is what they should be doing. They should be leaving that sucking need behind and moving to chewing.
And we can do oral reflexes, which the phasic bite is. And I gave you guys the oral reflexes and the hand-mouth reflexes. We can do that work from birth. And also Dr. O'Rourke talked about, and you guys talked about pre and post release, like any kind of a tethered oral tissue release. Mm-hmm. I go in, I get as much function as I can, and I believe you said this too. And that includes the oral reflexes, which we can be checking on from birth.
Right.
And so after we get the release, we're not only going to do stretches to keep that area so that we don't get scar tissue and have to have another release later and all of that. I mean, just like she said about midwives and that nail.
yeah, wasn't it? I've never heard that before, that they would have that.
I worked with 4 excellent IBCLCs. Oh, and we have 2 great IBCLCs that I work with here. So I worked with 4 great IBCLCs in Maryland, and they told me about that. So I laughed. So all that good body movement, good feeding, good mouth play, which includes kids do generalized mouthing in utero if you look at your sonograms. And then by about 5 or 6 months of age, they're putting their fingers throughout their mouth, and that's a good thing. That's called discriminative mouthing. So good mouth and airway, that leads to good mouth and airway development, those things. And then good mouth and airway development, as you mentioned, again in that presentation, is needed for good speech and swallowing. So if we don't have good airway development, including respiration here, then we are, and yeah, I love the way Dr. O'Rourke talked about nose breathing and how there's a whole lot that goes in nose breathing, like the production of nitric oxide, which is really good for the body. But I love the way she talked about the size and how the nasal breathing channels the air to the bottom of the lungs, which, guess what? That's where your capillaries are that are receiving oxygen from the body. So
I loved it too, that deeper breath that you can take because you have that more narrow airway.
Right. And we have 2 articles on our site from David McIntosh from Australia. He's an ENT instructor at a university and a working ENT in Australia.
Okay. Did you happen to see, Diane, the parents article that actually just came out, which rarely does what we do get any real exposure, but to a parents magazine, we were shocked by it.
Thank God.
We talked about
Thank goodness.
Thank goodness. It finally started talking about sleep disordered breathing and how this looks like ADHD, how it can look like a million things, but it just talking about sleep disordered breathing in kids. I was so excited.
And heart problems. I mean, people who mouth breathe often have concomitant heart problems, and he explains that very well. So my website is also one where I'm not going to be putting up new blogs and Q&As because I want to move in this other direction. But having said that, I have a lot on there. So, and I always tried to make it, because I edited it, to be consumer friendly, whether you're a therapist or whether you're a parent. Okay, so now in children and adults, what you'll see that's going to be on the homepage of the site when we finally get it there. Good posture and body movement, plus passing a simple oral examination. Okay, plus appropriate eating and drinking will get readiness for the sophisticated oral facial myofunctional work that we do.
Right.
And the sophisticated speech sounds. And so we have a lot of people making their speech sounds in the bottom of the mouth because they've accommodated, and they sound fine, but all speech should be between the tongue and this upper jaw called the maxilla.
Sure.
Okay.
Yeah.
And so what we saw big time in our breathe class with all the patients that the therapist, it was dental people. We had orthodontists, dentists, oral facial myologists, speech language pathologists, and I don't know, lactation people. We had a whole bunch of people who took that course. And like I said, I finished my work with them. So my stuff's all on video for them and whatever they choose to use. However, we saw over and over, in every age person, if they didn't have good eating and drinking skills, and they couldn't pass a simple oral exam, which we were taught when I went to school, we were just getting into language, but we were taught no matter who crosses your doorstep and why, you always do a simple oral exam.
Right.
So we saw all these people that couldn't get tongue tip isolation. They couldn't get tongue and jaw dissociation, their jaws moving with their tongue. They aren't properly managing food. They're doing a lot of chewing, even adults up in this, what we call the premolar area.
Right.
They're eating on one side. So anyway,
And don't you find though, Diane, that even, I don't know how many like students you work with, but even when I go in to talk to universities or do my work, I still feel like the field of speech is so hesitant and shy getting in to do any kind of manual therapies, understanding how muscles work, how oral reflexes work. It's just, it's not necessarily the mainstream idea. Like we're taught dysphagia, we're taught evaluation and treat kind of thing, but I'm just finding students come to me and they're not aware of the muscles of the face. They're not aware of how they move, what they should be doing, what reflexes drive them, you know, the hierarchy of it, and the importance of understanding that we can't just, you know, flash a picture card, that we have to get in there and move those muscles and make things work. And you're seeing that. I mean, I'm still seeing that.
I've worked with a multitude of students and I love them and I miss them. Yeah. And so having three freestanding clinics at Loyola, I was able to go between them and work beside the graduate students.
Sure.
So that they weren't just sent in there with a plan, but they got to actually work alongside me, and then I could turn, over to them. Mm-hmm. And then when I was in private practice in Maryland, I alternated universities. Mm-hmm. So I would take a student one semester from one university and a student the next semester from another university. Mm-hmm. And then I came here and there was no university that had a speech program except in Reno, which may as well be in another country because it's so far away. I love Reno, don't get me wrong. Again, I'm not speaking against Reno.
Right.
But the thing is, we now have a speech program, which I'm not going to be teaching in because I want to move to really moving beyond the basics, which I taught for so many years, sure, to really getting results. Mm-hmm. And one reason I don't feel, and I did have one graduate student until COVID came along, and she actually came from Wellesley in Boston.
That's funny. Pretty far.
Well, she was living here at the time, making money for graduate school, so she needed some hours. So It was fabulous having her. But you're right. The speech programs aren't training this. Now, there is one in Brazil. Mm-hmm. Which Rosanna Ramirez graduated from. She has a master's in oral facial myology. I think she's in Savannah, Georgia now. And so there's one program there. Yuli, she's got two other names, but if you want to know her website or anything, you can ask me. She's in the UK and she just got her curriculum accredited.
Okay.
So there's a start there. At Loyola, we taught from, my first course was 1989, and I finished there around 2001. And so, but the reason you're seeing this problem is there was this big controversy.
Oh yeah.
In speech pathology. Now, Ray Kent, who's another one of my mentors, and is fabulous. He did a great article in 2015 for therapists that talked about the relationships of everything. So really what you do in feeding, you develop tongue cupping, you develop tongue tip isolation, you develop the back and base of tongue. Now, who did I study swallowing with? Jerry Logeman. Mm-hmm. So, I've had the best teachers. And so that's another convenience I had that many people don't have. Right. However, I had to figure out why things work in order to teach students.
Right.
And then what you see here, this is what I do with parents and therapists.
Sure.
Because I want to get them started one thing at a time. I want parents to do something that fits into their home program. So for example, oral massage that can include some jaw work. I like these ARC oral probes because you can also chew back here. And kids love to chew. By the way, that's how they get teeth.
Right? They do love to chew. Easy ways.
So you can add a little bit of jaw work, chewing work into your oral hygiene. You can start oral hygiene. I loved when Dr. O'Rourke said she'd like to know about the babies before they're born. Me too.
Absolutely.
Because we saw like so many children and adolescents with Down syndrome. We saw many from birth.
Right.
And so we had parents calling us when they knew they were going to have a baby with Down syndrome.
And I've not heard another dentist say that, so I thought that was amazing in terms of having.
And you know, Dr. Nora, who is Suresh Zaghi's wife and is a pediatric dentist, you know, she started her oral hygiene with her baby like we used to do in the 70s with like a baby washcloth, or you can use, we have cheesecloth. I've got mine around here somewhere that's unbleached, and you can throw it away when you're done. And so we were taught in the 70s to go in and do oral hygiene from birth.
Right.
So we went in and wiped the gums and did all.
Yeah, and I think that's lacking, any of that hands-on, just like you said, babies spending too much time in their back, babies spending too much time with artificial devices in their mouth. And then we're scared to get in there, and then parents don't necessarily know what they're looking at. And then from what we see, you know, information that they're getting when they go ask a question is, it'll be fine. Or I heard recently, you know, mouth breathing just corrects itself. It's okay. It'll go away.
I was a mouth breather, a bottle feeder. You know, I've been through it all. And so it doesn't correct itself.
Right.
And so the thing is, what we have to do though, and so I have this group of sample recommendations that I use, and I think I may have sent these to you.
Good.
I don't give all these at once. Sure. And I always tell people, please read the top, because it says treatment cannot cross state lines, but education can.
Yes.
Okay. So, and that's what we're doing.
Right.
Educating. So I also say, you see my office here, it's a little messy because I haven't been treating, but I always had a video camera running with an SD card, the parent right there doing the work along with me doing the work on the parent as well. And then I gave them the SD card as they walked out the door.
Right. And how important is that, Diane? How important is it?
Very important, because while we're doing the work, I'm explaining why they're doing it.
Right. And if you don't know, if you don't understand it, you don't have the buy-in to go home to know how important it is to get some of that chewing in. But if you have some of the background and you have this wonderful information, you go, oh, this is for long-term airway health. Every parent's going to do it. They want the best for their child.
And I tell them, look, don't fret about this. What I want you to do is, here are two things that you can start with. And usually, depending on the age of the person, the child, I will start with oral massage for awareness and discriminative mouthing. And we can incorporate that into toothbrushing and oral hygiene. And so I want everything I do, as your friend Terry would do, and my friend Tanya, we want to get these into activities of daily living. These are all habit systems. So it takes some practice. It takes 2 to 3 weeks, sometimes more, to develop a habit. So I'd rather go more slowly and get it into the habit system.
Right.
And then I tell the parents, look, don't sweat it. This is an hour of treatment. If you're cooking dinner or something and you want to just stick it on.
Right. Exactly.
You can kind of listen to it, or you can zoom through it, whatever.
I tell parents, you don't have to watch me. You can just put me on in the car and then I just talk.
You can put me on in the car. You can do any of that. And then the second thing I move to is jaw work. And I start this with newborns. And so if you want my free e-course on newborn and infant mouth development, I start using the phasic bite response back at the molar areas where the molars will come in. And this is very important because it gets the tongue retracting, which is very important for swallowing. So I learned a lot about back and base of tongue from Jerry Logeman. Everybody thought she just worked with adults, but she also worked with children.
I didn't know that she worked with kids.
She did, and she taught us about cerebral palsy, that And Suzanne Morris taught us so much about structure. So babies, even babies with Down syndrome, we have a lot of babies. I have an excellent holistic pediatrician in LA and one of the best IBCLCs in the world who I consult with. And both of them, and I'm not going to say their names because I don't know if they want me to, but they both have confirmed that they're seeing baby after baby after baby now being born with on the low side of normal in terms of muscle tone.
Okay.
So if we know we have that,
right,
and we don't know why, the pediatrician thinks it's a metabolic issue. The IBCLC thinks it's a birthing process issue. Not that there's anything done wrong, but you know, we have these medications and things.
Sure.
Other IBCLCs, and I put this in my book, who I work with right now, think, you know, we're all more sedentary. So the babies aren't getting as much movement because we're not moving. So we don't know why,
right?
But we have to be aware of this.
And what's the implication for us, Diane, as SLPs, when we see a child come in with low tone?
So that's why we have to get them in sideline. We have to track them. And it's very simple because what I've given you from Lois Bly, from Shirley German Volpe, from others, it's all literature based, but I put it in regular language. Sure. So when, like, for example, when your child is on the side, you should see the hands coming together and coming toward the mouth. I mean, it can't get any simpler than that.
It can't. So when we see a child though with low tone, what is that? What's the implication for their feeding and their speech development? What do we see?
You know, I have low tone. My daughter has, I don't know if I ever pronounced this right, but I had the pleasure of editing for Christian Guilleminault of Stanford, who wrote a lot of the work that we're basing our treatments on these days. And so, and the reason I edited is he was French, and, you know, I helped him with getting things in English as someone who understood his work.
Sure.
So he spoke good English, but he often worked with people throughout the world, and then they needed somebody to help with the APA format and that kind of stuff. So because I was a university person, I was able to do this. So there's this thing called ethos Danlos. I don't know if I'm pronouncing it correctly, but when I was growing up and when my daughter was growing up, we actually thought hypermobility of the joints was a good thing. Okay. Because those are the people that could do splits.
That's a good measure.
Whereas I have low tone in my body and I'm a fixer. Mm-hmm. So if I don't watch out, I'll fix my shoulder girdle to get it stable. I'll fix my hips to get it stable. So we have to watch. It's not high tone when we see what's fixing. They kind of just hold this still. And what I do in one of my classes is this, is I say, okay, we're going to talk about stability. We need to have what's called dynamic stability. So you see as I'm moving here, I'm also moving my shoulders, my hands. I can't talk without my hands. And so there's a real hand-mouth connection, by the way, including the use of hands in expressing speech. So I'll have them do something like this. I'll say, okay, I want you to raise your shoulders, fix them, bring your arms in against the body, and now I want you to write your name. Mm-hmm. That's stable, but fixing.
Right.
And a lot of people call that high tone. It's not, it's fixing.
Right.
So we have to watch out for that.
Right. Now we'll see that in the face too.
They do. This is the one.
Big one here.
A lot of this.
Those on cheeks, but this is real thick.
B's and M's. And these are the people that develop what we call trismus. They don't have a good wide jaw opening. Mm-hmm. So then I have them write with stable but mobile shoulder girdle, mm-hmm. and they feel the difference. But it is the same in the mouth. So I had one 16-year-old who was still drooling, very smart, had been in speech since 18 months, still had an R distortion, had an oral facial myofunctional disorder. And her mouth was like this. really low tone all over the place, because gravity pulls down on this heavy bone. And if your muscles don't stay in shape through appropriate eating and drinking primarily, but there's other ways to get, simple ways to get them in shape. We've now, what we did during our Breathe course and what I'm doing now is I really cut down on the number of materials I use, because I don't feel like I need every material in the world. So anyway, but we need certain movements to keep our mouths in shape. So as I'm going through my own orthodontic work, and it's been a 2-year process so far, and getting the palatal expansion, I do bilateral yellow chewy tubes. That's all I need. I do 3 sets of 25 a day. And you can start this as young as 6 months if you're sitting with the child. But prior to that, I have them doing
going around
this kind of stuff. But as soon as I can get the feeding going at 6 months, you know, we're going to do things to get the food moving around the mouth in an appropriate manner and a safe manner. And that's why we have things like, this is a safe feeder where we put just a chewing size piece of food in.
Yes.
And we can get that.
And can you speak a little bit, Diane, to the fact that the things that you're saying, you're talking about a good oral motor exam, you're talking about airway development, all these muscles, these oral reflexes and chewing, you're giving us all this wonderful information of things that need to be in place.
Right.
And so what of these behavioral feeding programs that are around?
Well, you know, feeding is really 3 parts. It's muscle function, it's motor planning. And back to speech for a minute, that controversy was really about motor planning. So we use, so while in feeding, we develop tongue cupping, we develop tongue tip isolation, we develop tongue and jaw association. Right?
Right.
In speech, we use back and base of tongue, because when you talk, if you counted 1 to 25 with me, which is a Sarah Johnson exercise, you would notice your tongue in retraction, but not stuck back there like that.
Right.
So we need tongue retraction dynamically. We need tongue cupping for a lot of our speech sounds, and we need tongue tip to work in an isolated manner. So a lot of the kids who have been, so this child, actually one child, 16-year-old adolescent, she was very smart, applying to colleges, but she had dysarthric speech because she didn't have good muscle function. So that's the first thing I had to work with. The next thing you have to work with is motor planning that's appropriate for the process. So the processes are different for eating, drinking, and speaking. Because if I used my IOP, I could show you the pressure differences. There are pressure differences in eating, drinking, and speaking. And I also have palatometer here that was developed by Sam Fletcher. And so I have a lot of instrumentation I can use to see what's happening, to be sure they're getting the right motor plans for eating and drinking versus speech. Okay. And then the third thing is behavior. Behavior is communication.
Yes.
So when Dr. O'Rourke talked about behavior she's seeing that she wasn't seeing 30 years ago, it's because we have so many kids who bounce all around because they're trying to raise tone, muscle tone in their bodies. See, when I went to school, we had jump ropes and balls on the playground while we were waiting to go in. We had a morning recess, which was structured. We had a lunchtime recess. We had an afternoon recess.
A lot of movement.
So we had a lot of movement, and people are starting to get back to this. And some teachers are having their kids stand or kneel. And that's something Terry could definitely address.
Yeah, definitely. So when parents, though, when they're concerned that they have this picky eater, or
Yeah.
when I say behavioral feeding program, I mean like distraction techniques, or take a bite and you get to watch a cartoon for 5
Yeah,
seconds. You know, that
that's
kind of stuff exists. That kind of therapy exists. And so when parents
does.
come to me, you know, we talk about the importance of understanding all these underlying issues that the child can't communicate. So then they communicate through their behavior, through picky eating,
It's not
that there's
normal,
an underlying issue.
but it's not going to get you where you need to go.
Right.
So let me just finish about the 16-year-old.
Oh, go ahead.
She's got this mouth that goes like this, and her tongue goes, and if she's 16, she's smart. She's still drooling on her papers. You know, so, well, we worked it out.
Right.
Her mother comes in. Guess how her mother talks?
Okay.
Like this. Same problem. Her
Right.
mother has fixed her jaw.
Same problem, different solution.
Terrible TMJ problems. And
Yep.
she doesn't have a good range of motion.
Yes.
In terms of opening her jaw comfortably.
Yes.
So these things do run in families.
Mm-hmm.
You know, so the low muscle tone runs in families as well. All right, back to behavioral. So when I went to school, I think B.S. Skinner was still alive, and they were chipping kids to death. And what I mean by that is, if you did what you were supposed to do in speech and said the word or sound properly, you got a chip in a cup. Right. And I'm looking at it thinking, this is really not for me.
Right. Agreed. Agreed.
So I never did that kind of therapy. But then I have seen the results of programs where they don't go further. What's good is many of those programs have started, they brought in OTs, they brought in SLP feeding therapists, and they're starting to get more balanced.
Sure.
But I went into one where they had these toys that every time the child took a bite, this monkey jumped up and down and clanged. I've been into some where they put a video on. I've seen the distraction even on YouTube being recommended to watch something. And so when I walk into a situation like that, I don't just rip the stuff away. Mm-hmm. I look at it as, how can we slowly move these things out?
Right.
And part of the problem, and one of the things I say to people that get my sample recommendations, please read the top. Parents need to be eating with their children. Mm-hmm. Children have mirror neurons. I know they say kids with autism. I have autism running in my family. I've got 2 siblings, and I have 2 grandchildren. But, you know, it's all worked out well for all of us because of who we are and what we know. But the thing is that a baby, even at birth, can imitate a mouth movement. Mm-hmm. So we have children being done to with oral massage. Right. Instead of adding it to toothbrushing and the parent doing their toothbrushing at the same time, or what kids really love is to brush your teeth along with you. Right. And so, and the same with eating. We have kids being fed separately. So it's not really a meal time.
Right.
And then and again, parents, I want to say something that I thought of before and didn't say. Okay. This is a no guilt conversation for parents or therapists, because believe me, I only know what I know because I've been doing it for 41 years and I had my own child and I have 3 grandchildren.
You had to learn it at some point, right? At some point you didn't know it either. That's what I always tell parents. Exactly. I learned it too.
And I wasn't always getting the results.
Right.
But see, when we did get results is when we trained all the feeders at the School for the Blind. We created dining rooms with music on in the background, and we had people that, you know, kind of ate their lunch along with the kids. Now, if they were feeding a kid, they wouldn't be eating their lunch and feeding a kid. Right. But there were good role models.
Right. It was more of an experience.
Yeah. But when it's your kid, I mean, there's no reason. And this is one of the things I would study with Suzanne for about a week at a time. So the last time I went, a therapist couldn't come. So I went and I was the sit-in therapist. And what Suzanne did every day, even with snacks, because we eat like 5 times a day, if we have snacks, healthy snacks. And that's the other thing. We have kids eating too much stuff that's not healthy. So, and there are ways we can take healthy stuff and make them safe.
Right.
So, Suzanne always had the parents sitting there with the child eating something.
Right.
At the same time.
Right.
And it's the same with jaw work. If I have parents doing this, work with their children, I have kids that yang. We use yang, 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 yang. We call that the walrus. I have kids that are doing that all the way to therapy. And believe me, if I don't do this with all the mouth changes I'm going through, my jaw pressures on the IOP will change where they're not equal.
Yeah.
The other thing that needs to happen is, this is the Lori Oberlin technique. If you watch people from Europe and other places, because we're getting so many of these shows on TV now, it doesn't have to be the oyster fork. These are really inexpensive on it's like 10 for $6 on Amazon. Okay. But this is a much safer way to use a fork. And so even if it's a small fork, when you watch people from other cultures who eat this way, they place their food further back.
Interesting.
And if you watch their masseters, these muscles here, you'll see them working.
Wow. Yep.
Whereas so many of our kids never get beyond cheeks and lips.
Right.
And managing everything up here. Again, I'm not against baby-led weaning, because Jill Rapley and I taught at the same conference in Calgary years ago. And we are not introducing our foods like we should be. We really need to be safely and carefully introducing foods. And that's why I put all that stuff in these books.
Which is such a great.
They will be in your checklist too. And so the thing is, we can introduce one food at a time. So we are careful about allergies and sensitivities, but this could be just a steamed carrot strip.
Sure.
And then in this book, I have 3 sets of foods listed. Some are the most allergenic. Some might cause allergies and sensitivities. And there's a whole list of those that usually don't cause allergies, and they're healthy foods.
Okay.
So, we have to work our way. Nobody's sitting in front of you when you eat your dinner and going, "Oh, Stacy, yay, you took a bite."
Right. That'd make me feel weird, Diane. I don't want that.
And the other thing I find is the parents, and again, no guilt on the parents, they didn't learn to eat and drink properly. So I have a list that usually what I start with is the family getting awareness of how they're eating and drinking.
Sure.
And then if the kid's old enough, well, even a 6-month-old, when you take them to the grocery store, or if you're shopping online, you can say, okay, so here's a picture of broccoli, here's a picture of cauliflower or asparagus or green beans. So you put 2 pictures up that you'd like to have for your family. And then whichever one the kid looks at, or if you're in the grocery store, even better, because it's 3-dimensional.
Right.
That's the one you pick.
That's the one you pick.
And, I have kids, I don't want them having to sit in a high chair while the whole meal's being cooked.
Right.
But as soon as they can participate in not just selection, but also preparation. So my other office had a full kitchen because it was an apartment. And so Melanie Potock's work talks a lot about this. Right. And, so we just need to get kids into food as age appropriate. So back to baby-led weaning, it's great. Jill, I watched her research, and she had the babies breastfed. And then around 6 months, she actually started with some very safe foods in the front, like steamed broccoli that a child could hold like a broccoli tree.
Sure.
She would cut the pineapple so that she kept the outside on and the child could hold it and kind of go like this.
Okay.
What's happened now is a lot of times people get to that point, but they don't get to where they need the child to learn to move and manage the food all around the mouth.
Right, right. Got it. Well, Diane, this is a wealth of information. Let's summarize. There's so much, and I know we could talk literally all day, but summarize for us. I'm going to put your website on there. You have some checklists for us. I'm going to link your books just to Amazon or to your site. Where do we purchase your books?
I don't sell anything.
Oh, okay.
So it's when you go to my site, you will see the links to where it's Target, Amazon.
Got it. Okay. All right.
Talk Tools, Future
Sure.
Horizons.
Sure. Okay.
Yeah.
So I will link all of this wealth of information, and I know there's, and then you gave us a beautiful PDF that's 38 pages long. So if you guys are listening to this, and which is great, if you're listening to this and you're not watching us on YouTube, you can go to YouTube and download. And actually, yeah, and
you don't have to print it out because my printer's running out of ink. So. But what you can do is save it in a place on, and the same with that pre-feeding skills book that Stacy showed. You look up in the index what you need when you need it. So this book has parent guides and topic guides. So please don't overwhelm yourselves.
Right.
Look up what you need, when you need it. Be easy on yourself with your child. Know that you have a lot of time ahead of you. I often say, look, you guys have your whole lives ahead of you, even if it's a 12-year-old, because let's get this stuff back on track for a 12-year-old. And we usually start with eating and drinking. And then because these are kids that have been in speech forever and they couldn't get the movements because they didn't have the basic larger movements in eating and drinking.
Right.
So then we can work on the more refined movements for speech.
And that's a good point. And also I was thinking, as I was going to say, if you felt like you needed a little more information, we obviously do free consultations, phone consultations at Family Tree, but a lot of our listeners, as I look at Buzzsprout, it's not just Grand Rapids anymore. It's literally all over the world. Our second biggest country is actually Australia. Thank you, Australia.
Yeah, mine too.
Which is great. So the last question maybe you could lead us to or lead us down this road is when people do have concerns, or if they're looking at your book and they are seeing like, you know what, these milestones are not being met and they are trying to find a therapist in their area, yes, what kind of questions should they ask? What kind of credentials should they look for so that you know they're in the right track, or so that they know?
So here's the deal. I will go back into limited mentoring and consultation. Honestly, I had to stop working for a few months because I was totally burned out, and it's no good to work with a burned out therapist.
No, it's not. Make sure they're not burned out. That's question number one.
So because I'd been working so much,
yes,
for such a period of time, especially with COVID, I was trying to keep so many things going. Mm-hmm. So I would say, if you're offering educational consultations, you and Terry, I would like to see them start with you. I will do some again. So, and also the book, this book can be purchased in Australia, and the Australian company that sells it is listed on the site. So I've taught in 3 cities in Australia. I've taught in Europe. I've taught in Hong Kong and Singapore. Everybody is ready for the information now. So if you, Stacy and Terry, your colleague, can start a list. I mean, Feeding Matters is a great place to start, right, but sometimes, which I love, Suzanne Mars, Marsha Don Klein, and parents develop that group, but sometimes the kids are so complex that they need more than just, I have one right now who I've been working with, and she's flown her kid all over the country, basically. And that's not a good idea.
Right.
So I think if they start with somebody like you or me, or if you have other people who are like us,
that would be nice. They're hard to find.
Just run some things by.
Sure. Yes.
And so there's Feeding Matters. If you want orofacial myology, I'm a member of the IOM. So there's that. But know that, and this is something I say at the end of all my presentations, not all therapists are created equal.
Yes.
And there's nothing wrong with that.
Mm-hmm.
So if you, and also Dr. Now, when I talk too long, I get a little brain thing.
A brain fog coming. I know.
So the doctor we've talked about throughout this, what's her name?
Which doctor? No, I'm getting brain fog. Oh,
one
Dr. O'Rourke? My doctor. Yeah, Dr. O'Rourke.
Right.
Yes.
So one of the things she said to parents, and I believe in parent intuition, and she does too, and so do you. So if in your gut you don't feel like you're getting what you need, keep looking.
Yes, keep asking the questions. Keep looking. You know, when the therapist you've landed with is answering your questions sufficiently and you feel guided and you're seeing change, that, yeah, we're not all created equal. We don't all have the same background, and it's important to keep advocating. And
one more comment that I was going to make earlier that I will make now is parents and therapists, the problems we're having are not your fault.
Right.
Okay. It's because medicine, and Dr. O'Rourke said this too, has become so spread out with all these different specialists who aren't necessarily connected.
Right. Right.
And the other thing is, when I started teaching in public school with typically developing kids for the most part, we saw our speech kids 3 sessions a week, and they did homework every night, which I checked. If they didn't do their homework, they didn't progress on the speech speedway.
Yeah, I think that'd be hard to come by with the caseloads these days that people could be seeing.
The language has done this. So I was there as the language became part, and just about, you know, I found all these language cases, which I love language. I have a master's which focused on language. Mm-hmm. But the thing, and I also know a lot about reading and language and all that. However, having said that, our language kids we saw twice a week. And if they didn't do their homework that I checked every time they came in, we had small groups, like 3, 2, 4 at the most. They didn't do their homework, which I was checking, then they didn't progress along that speedway.
Right.
So eating, drinking, speaking, swallowing, breathing, they are all habit systems. Mm-hmm. And so if we don't practice good habits on a daily basis, and we don't do them enough and systematically enough, and that's the problem with sometimes, I'm not against the tools. I work with talk tools. I love talk tools. I love ARC, Debbie Lowski. Mm-hmm. I love Luz Arias's work and so many others. But the thing is, you have to have somebody to help you choose the tools you need.
Right.
And that's why I did that general course for so long, because I wanted to tell people, here's where this is, here's where that is, this is what this can be used for. But you need a therapist who is not going to give you a program that you feel overwhelmed by.
Right. That proper guidance is going to be really, really important, and working at your pace.
And it's family treatment. Jenny McLaughlin, Jenny Hyatt McLaughlin, who's written about the STEPS program, Nina A. Johansson, both of them are on the same page as you and Terry, because they are really, this is really family treatment when we're talking about feeding.
100%.
Right. It's not just take your kid down the hall, you sit in the waiting room, and I'm going to fix in 1.5 hour session a week your child's drinking.
No way. We need the family so bad. Right. We're the guides, but you guys implement, and yeah, we'll do it with you as a team. So
okay, so I know you need to go.
Wonderful.
I over to you and to your audience, because you have a fabulous audience tuning in.
I know. Wonderful people. And Diane, thank you so much for your time. This was amazing for you to gift us all this information, 40 years of experience and all of these resources. I mean, I'm a huge fan of yours and your work and your contribution to our field. So thank you so much. And once I have this all edited and put together, you'll have to go over it because you gave me so much. I don't want to miss anything.
I love the way you do it, the way you and Terry do it, and you put certain comments, you know, into the part of the video.
Yeah.
And the one thing I want to say to the therapists and the parents listening, or the families listening, so you might be a family member of a 99-year-old who's also working with feeding. So I want to say to you, please do not get overwhelmed.
Right.
Because it's very easy to become overwhelmed, because this is not as difficult as it seems.
Right. Right. I know. But the things we do sometimes are so minute and so small. It seems like, is this going to make a difference? And we're your cheerleader as a therapist. So
well, I'm guilty of it. I mean, I'm a therapist that knew all the tools, and I overwhelmed them, and I had them get all the tools I thought I would be using because I wanted them to buy it once. But then I was always there every week, either at home or in my office, working right along with them with the tools. So we didn't introduce all the tools at once.
Right, right. Yeah, we don't have to do that. So wonderful. Okay. Thank you, Diane, so much. I appreciate your time. I'll talk to you soon.
Okay. Thank you, Stacey.